Yeah, so these are some of the topics that we're gonna hit up today. So plethysmography, pulse volume recording, that's what we've been doing in lab. So now we're just gonna kind of learn a lot of the theory behind it, understanding what those numbers mean to us, what our waveform charts, our pulse volume recording, the waveforms that we get, what they, signify in terms of potential disease, understanding how to read the reports, understanding the segmental limb pressures. We're also going to discuss a little bit about treadmill exercise. So this is basically what we do, that PVR or SLP, except we have the patient exercise to try and induce claudication, try and reproduce those symptoms, because one of those criteria for claudication is those symptoms are repeatable. We can reproduce them in the lab. So that's when we try and get them to exercise to create that cramping feeling that they were, or pain that they were experiencing. We'll learn a little bit about another test called the reactive hyperemia test. So this could potentially be an option for patients, who can't ambulate, we can't exercise them on the treadmill. Say, they're diabetic, or, we've had to amputate, they don't even have feet. How we expect them to walk, so we can do this hyperemia test. We'll learn about another test called the transcutaneous oximetry. This is another, I want to say, indirect test. So we don't actually, these are all examples of indirect testing. So we're not actually imaging the vessels themselves. So we don't get pictures of the vessels. We don't know exactly, where that disease potentially is. We can kind of get a general idea. So with this transcutaneous oximetry, we use that to measure oxygen saturations within the tissue. And that helps to guide doctors when we're talking about amputation and healing potential of wounds. A couple other tests are continuous wave Doppler. That's just listening with that little pencil probe, listening to the actual pulses. We can do a Cold's challenge test where we actually cool the extremity to try and.
She said it keeps going in and out. She doesn't know why.
Okay.
I'll tell her it's probably the Wi-Fi here.
I keep going in and out, or she does?
It's probably her Wi-Fi.
I hear you now. I heard her for a second.
He's like, oh no.
Just go back to bed, Maddie.
Yeah.
It's 6:30 over there.
Yeah, it is. And then the last one is this thoracic outlet syndrome test. So that's an exam that we can potentially do in the lab to rule out vascular disease as a result of compression of the vessels between that first rib and your clavicle. So we'll go into all these in a little more detail. Just some general background about some of these arterial tests. So they're considered, again, indirect because they're non-imaging. We don't actually acquire images of the vessels that we're examining. They provide us with good information to determine the presence or absence of arterial occlusive disease. So that test that we're doing now, that PVR-SLP, what we do in the lab, that's a good baseline for us to determine, does this patient have peripheral arterial disease, yes or no? It's a lot easier to perform and a lot less tedious than having to do an arterial duplex, what we're going to be doing after this, where we actually have to image each artery going down the leg, looking for specific areas of stenosis. That could be quite time consuming, quite challenging, whereas we can just, even if we want to, just do an ankle brachial on this instead of even bothering with all the cuffs, just see what's going on by each ankle, that can kind of give us a quick baseline.
I sat through, I sat through 4 of those on example of this past Friday.
Where were you?
She had at Polydromet.
Oh,
Yeah, she did the arterial and carotid.
Okay.
Yeah. Back to back.
Yeah, it's a little different, right? They got to do each segment at a time. They don't have,
Yeah.
I've heard. But yeah, they do some vascular now, polydroma. I'm very happy with that.
Okay, so I'm like, how did you witness this? Like,
Yeah.
that's fast.
like that renal, she did a renal study on that guy forever. She had to get the pressures on every single teeny tiny little vessel in the kidney. And my gosh, it was like, it almost took 2 hours. It was so, because he was had all kinds of issues.
So these indirect tests, these non-invasive tests, they're fairly simple to perform, they're less time consuming. You know, we could get a kind of a general understanding of how severe the disease is. The general location where the disease could potentially be. Just the limitations, again, we don't have the ability to find that precise location of the disease, you know, where exactly is that stenotic lesion, you know, within that vessel. And the diagnoses tend to be more generalized.
I lie, I think my mom needs to do this test. I'll sort of diagnose it girls after.
Can you record this lecture and then post it? That's what she would like, if that's okay. Because she said she's having a really, really hard time.
I'm sorry, I forgot. I uploaded it to my laptop and down.
I'm gonna fail this test. Just had to read the article. So yeah, you can post both and I'll go back and watch it again. I'll remind you. I'll bother you.
Yeah, it's recording.
Is it?
Oh, there, yeah. Cloud. So these are just our segments of our vessels. So again, just become familiarize yourselves with your vessels. There's a couple different terminologies that we use when we're talking about the lower extremity arteries. We break it down kind of into segments. So we refer to the more proximal arteries as the inflow system, this aortic, aortoiliac inflow. And then once we get past the level of the groin, we get into this outflow system. So that's like our common femoral artery, common femoral.
Superficial femoral.
Yes, SFA, profunda.
Teacher.
So what you're saying is we don't need to memorize.
So basically like. So basically the way I remember it is the vessels that are flowing into the leg. Aortoiliacs are part of the inflow system, and then outflow is all that's flowing out towards the foot. So into the groin and then out towards the leg. Once you get down below the popliteal, they refer to these as run. That's your posterior tibial, peroneal, anterior tibial, dorsalis pedis.
Dorsalis pedis is number.
It's not on there. It
Nope,
would
just
be,
kidding, it's not.
It would be an extension of your anterior tibial. So anterior tibial, most lateral,
I thought 11 was the
posterior tibial, most medial, peroneal. So you had to look at that. So this is like patient's right leg. This is the most lateral, most medial.
She said she's sorry, she didn't know why she's sniffing. But it's probably her end, I told her you're gonna post it, I doubt she probably don't.
I'll say, yeah, you have.
Wi-Fi.
What's this? Oh,
Plethysmography.
Yeah.
Plethysmography. So when we see that term plethysmography, that refers to a way that we can measure volume changes. So what we're measuring for us is volume changes in blood flow as it's coursing through the different segments of our leg. So as your heart beats, it expands, blood enters into the segment of your calf or your thigh, expanding those cuffs, and we get those tracings, those waveforms as a result of volume changes. So plethysmography refers to volume changes. So for us, that exam that we do is that pulse volume recording. So we're measuring the volumes of your pulses, how much blood is entering or passing through those different segments with each heartbeat, and measuring the volume changes on our tracing. We also have something called photoplethysmography. So those are those little light sensors, those infrared sensors that we attach to the patient's digits, to their toes, their fingers. Oh God. So photoplethysmography is not considered a true plethysmography because it doesn't really measure the volume changes. So it falls under that GEIS, but it's not considered true plethysmography. This PPG, this photoplethysmography.
So plethysmography is a
So wait a minute.
super-
No, I'm
Sorry,
sorry.
go ahead.
No, it's a way to measure volume changes, but So there's a couple different types of plethysmography. So I kind of just,
And you said photo, it's,
it uses a photo sensor, but it's not considered true plethysmography. Because it's not actually measuring volume changes, it's measuring like the number of red blood cells. So there's, I get rid of that. There we go, plethysmography. So again, measures volume changes in the extremities. So with plethysmography, we can use this to differentiate true arterial claudication from a patient who's having pain from a non-vascular source. So if our waveforms look healthy and we don't see any evidence of disease and they're having pain, then it's not going to be a vascular source that's causing that pain. So we can use that to kind of rule out that. We can document the functional aspects of arterial disease. So we can see just how much blood flow is getting down the extremity based on what our waveforms look like. Again, it can be used to detect the presence or absence of arterial disease. So we can say yes or no, this patient has peripheral arterial disease, yes or no. And we can use it to kind of localize the level of the obstruction. So we look for changes in our waveforms as we're going down the leg, which can indicate, the presence of disease. We can also use it as an assessment, say the patient's had some sort of interventional procedure that we've gone in, we've done angioplasty, we placed stents, we did a bypass graft. We could tell, if that procedure has had profound or significant impacts to improve those patients' symptoms. So plethysmography does have some limitations. It's non-specific to a single vessel. So if the patient has collateral vessels or if the disease is below, like below the knee where we have multiple vessels that are involved, we can't single out like, all right, it's anterior tibial, it's posterior tibial, peroneal. So that's one of our limitations. It's less diagnostic than isolating disease location than with our Doppler. So with the Doppler, we can tend to isolate the location of the disease. You can't discriminate yet.
I was gonna say, so the limitation itself, so the plethysmography is only good from like the groin to your popliteal, in a sense.
We could use it for higher up. But like if they have collaterals, we can't differentiate between collaterals. So we might get a normal looking plethysmography, but their main vessel is very diseased, but they've developed a lot of collaterals. Or maybe they even have a duplicated system, like if they have any sort of arterial,
So you could use it on your legs, doesn't matter what segment, it's just a matter of like if it's what did you say? It's I don't know what that word you just said. Collateral.
Yeah, so if they have like extra branches that are going around the blockages, like patients develop collateral vessels, those volume changes might still look normal because blood flow is going through those collaterals now. So yeah, we might not pick up, this patient's got really bad arterial disease in the main vessels, but if they've got good collateral circulation, then they may just appear as normal to us.
But wouldn't that be okay anyway? Obviously, no, because the collateral could eventually develop disease as well, but I mean.
When we say
Matter
collateral,
of time.
sorry, when we say collateral, like in a sense, like you're just talking about like walking.
So like your body will be like, you know what, I can't get blood through here, so I'm gonna like make
Go
new
where else, somewhere
vessels.
else.
Yeah, or like reroute itself. Your body does that shit.
It's a little weird. It's kind of concerning.
But it's kind of amazing.
Well, it's
too.
amazing. It's
Yeah,
weird though.
yeah.
Yeah, so I get like, this is my main vessel.
I was like, wait,
So
so
like where your body does it with other things too.
yeah,
Like to
Yeah, so like
irrigation
little fine channel,
and-
yeah, would be like being able to get around that blockage by going through this, taking a different pathway. So another little artery that exists, so your main line could be blocked and you have a single little lateral.
Okay, thank you.
Goes around,
Okay.
it's like taking the back roads or the side streets.
Yeah.
Some people have a lot of little side streets that develop.
So that goes back to like my first week of a question, like, do we know all the arteries out there? No.
Well, those
clearly.
little collaterals aren't gonna have names to them, like,
Well, that's
they're-
crazy.
because it's variable, not everyone's gonna have them, like,
But if you see them, you know something like, it's
Like,
not normal
what
in
the
that,
is.
it's- yeah.
Okay.
yeah, and they're so small, you're probably not even gonna really see them on ultrasound, like, these are really
Veins
teeny.
and arteries, right? It could be.
Like, wouldn't that also change the pressures? Like, why, you wouldn't have, I mean, how many would you need to have a normal pressure though?
Yeah,
Like,
you
there
need-
still should be a pressure change.
The pressures would potentially be different, just this plethysmography portion might look the same. The pressures are probably, the pressure should be less. Yes,
But the
Uh,
volume of blood.
the volume of
is-
blood, because you might have a lot of them. That's kind of. Like total surface area of them might be
enough.
more enough. It's also difficult to perform with obese patients. So if you can't get a good cuff wrapping, or if their vessels are very deep, we don't pick up those volume changes very well. And then just always
You
remember,
just have muscular legs.
yeah, that too.
I don't, yeah, I was gonna say, you kind of have to. It's hard.
Yeah, we want a nice, warm, comfortable room, because remember, if it's cold, those arteries are gonna contract, might skew our results. So here's a bunch of different kinds of plethysmography. Really, the only one that really exists nowadays are gonna be our pulse volume recording, and then the photoelectric plethysmography, that PPG. Just remember that this one is not a true form of plethysmography. So this is just kind of a little bit of history for plethysmography. So they all kind of work on the same general principle. Where we're measuring, we have a segment that we're measuring and we're trying to get our information from. And it's a cup that inflates with air. And then we try and measure those volume changes as the blood is pulsing through that segment. And then those changes are, those volume changes are transmitted to a calibrating device. And then onto an amplitude recorder, and then we get a digital tracing or it's not digital, like we get a kind of a tracing readout on paper now. So this is kind of like an old school method. So our pulse volume recording or our PVR. So with this, again, it's a volume recording that records the difference in limb volumes of blood flow in and out that occurs with each cardiac contraction. We can detect changes in volume pulses as blood moves through the extremities with each cardiac cycle. And this gives us a qualitative assessment, so kind of an overall assessment of the limb perfusion, how much blood flow is perfusing through that limb. So these PVR recordings are valuable when we combine them with our pressure measurements. So that's why we typically do both exams in conjunction with each other. So we do that initial pulse volume recording, and then we get our segmental limb pressures. It's particularly important or particularly valuable, these PVR waveforms, in patients that have a disease called medial calcinosis. So highlight that, that's important. So this medial calcinosis, this is a hardening of the medial layer. So it's a calcification, hardening of that arterial layer that actually causes the vessels to become non-compressible. So when we're pumping up the pressure, these are the patients down by the ankle, we're maxed out at 240, we can't even compress the vessel because it's become so calcified. So this is a common occurrence and a common finding in patients that are diabetic. Also patients that have long-standing kidney disease. So anyone that's been on dialysis for a long period of time, or they have known chronic kidney disease, they're in kidney failure, they'll oftentimes also have this medial calcinosis. So kidney disease and diabetic patients.
So it's just like hardening of the vessel.
Yep, so that, the vessel, so it's
Non-compressible.
very severe arteriosclerosis, because art is hard.
Oh my god. So it says medial, so I'm assuming it's more like it's
The
more
medial layer,
common.
the medial layer of the vessel, so
Okay.
your tunica, intima,
Oh,
media,
yeah, yeah,
adventitious, that medial layer,
medial.
that muscular, that middle layer becomes very calcified, very hardened.
You said diabetic and kidney
Kidney disease patient.
disease patients.
Yep. So these patients are gonna have artificially elevated pressures in their extremities, so their ankles might be not compressible, or maybe you can get a really high pressure, like, down by the ankles, and the rest of the legs are not compressible. So we can't really, figure out what's going on because their pressures are falsely elevated. Because we say when there's disease, well, we're gonna learn in a moment, as soon as the patients starts developing arterial disease, those pressures should start dropping. But if they have this medial calcinosis, those pressures are falsely elevated, they're falsely high. So their disease, their vessels might be really diseased, they might have a lot going on,
Mhm.
but because of this, the pressures aren't so bad. But then we look at our pulse volume recordings, our waveforms, like, no, they're not good.
Mm.
So these can help us in instances when patients have falsely elevated pressures, when the two don't jive.
Gotcha.
So if we're getting normal pressures, but our waveforms look like doo-doo, this,
That makes sense because I remembered.
I'm sorry, doo-doo, yeah.
No, go ahead, sorry.
No, I was just saying, I was repeating it out loud.
Oh, I
Yeah.
was gonna say just because that makes sense because when I was doing the class with Maddie, the pressures, like remember how I was like not compressive for one, but then we went back to the waveforms and looked normal.
Yeah.
So that in a sense, like that's what like if one's off, you just gotta make sure
Yeah.
the other. Okay.
Absolutely, yeah.
Okay.
So when we're wrapping, so the cuff width should be at least 20% greater than the limb diameter, or 40% of that limb circumference.
So one finger's
It was measuring that nonsense.
He was measuring, I know.
it's the one finger thing.
We're gonna wrap cuffs on different segments of the extremities.
I thought it was one finger.
Is it one or two fingers
One,
that you can fit in between the cuff and the patient?
you shouldn't be able to fit two
You
fingers.
shouldn't be able to fit,
Yeah,
so it is
one.
one.
Yeah.
Wonder.
Okay. That's wrong.
It got comps is on Wednesday.
That was not on the com.
So with this PVR exam, it's important for us to use the same amplitude settings and inflation pressures for each segment to ensure consistency and accuracy. So that's why Christiana, they set it for the arms, and then when they do the legs, they don't change that amplitude, the size of those waveforms. So we can determine, what's normal versus an abnormal plethysmography waveform. And then just remember that arterial disease is going to be proximal to or at the level of a cuff, showing the abnormal PVR waveform. So it's kind of the same thing as that symptomatic muscle, like arterial disease is going to be proximal at or proximal to that symptomatic muscle. So if I'm having thigh pain, the symptomatic vessel can't be something down here. It's got to be at or proximal that's to that cuff. So if I have my thigh cuff and that's the one that has the abnormal waveform, the disease segment is either at that cuff or something proximal. So iliac, maybe aorta. If it's my high thigh or high calf cuff that has the abnormal waveform, the disease could be at that cuff or something more proximal.
Now, is that same thing, because you keep saying waveform, is that the same thing for pulse? Like, what if it's an abnormal pulse?
That's
You're like-
distal, right?
I feel like that's 3 slides from now. We'll be talking about that.
If it's an abnormal pulse
Yeah,
pressure?
Yes.
Or
Great.
No, same thing with the pressure.
Same thing,
Yeah,
proximal,
so if I have that pressure, when we're looking for those pressure drops.
yeah,
Yeah.
So this, say like, this is
that and
my,
your calf are like,
or you wanna do these two?
sure,
So if this is my low, if I see the pressure drop from here to here.
yeah,
The disease has to be,
In-
between those two, so it's at that cuff
Or
or,
above, okay,
Above,
that
yeah.
is what my brain was being stupid and I was thinking.
so proximal to the calf, but distal to the.
Thigh.
yeah, I mean, if we see it, if it's just between those two segments, yeah.
Just wanna make sure, okay,
If it's my high thigh cuff. Like, that's, we'll get into that. We'll do the
Slide
pressure,
pressure.
yeah, we'll do the pressures later, don't worry.
okay.
Hold your question till the end of
I
the
know,
slide.
sorry, my bad.
No. So techniques for our PBR. So we can do this for the upper extremities. Again, I said upper extremity peripheral artery disease is very uncommon. And you're probably only gonna ever really do a handful of these. You might do maybe like 2 or 3 a year, it's very
Because it normally doesn't, you normally don't have issues there.
usually, yeah. And if they do, they usually just wind up doing an ultrasound reflex. So again, the majority of peripheral arterial disease is gonna be in their legs. So if we're doing, again, a 4 cuff technique, we have a cuff on, the upper arm on both sides, then we have a high thigh, low thigh, calf and ankle, and then we also place a metatarsal cuff. We also have the little cuffs if we needed to, for the great toes. So we have a little toe cuff that we could use, or we could just put our little PPG sensor on there as well.
With double-sided tape,
Our bootleg double-sided tape. Yeah.
so ghetto.
Those cuffs for this portion of the exam, you notice they usually inflate to about 60, 65, maybe 70 millimeters of mercury. We calibrate the scale on the brachial level. And then keep that scale throughout the remainder of the exam for easy comparison. And we want to try and record our PBR waveforms for each limb segment. Just remember, and then this is very sensitive to motion, so this is the one we have to tell them to stay still, keep calm, relax as much as you can. It's just showing the cuff placement. So there are some labs that do a 3 cuff technique, so sometimes they might utilize just a larger thigh cuff. Skip over that one. All right, so normal pulse volume recording waveforms. So a couple of things that we look for with normal pulse volume recording waveforms are we want a nice rapid upstroke, so a nice fast upstroke. So when we go from the beginning of systole to that peak systole, we want a nice sharp incline, a nice steep incline. We also look for what's called a dicrotic notch. So this is that dicrotic notch, it kind of bends backwards. So that dicrotic notch is one of the first things that we're going to lose in patients that have peripheral arterial disease. So that represents the separation between systole and diastole, that dicrotic notch. And then we should also see a nice gradual diastolic runoff as well.
Wait, what did you say that you're looking for in the dicrotic notch?
So this notch, this kind of
Yeah.
bending backwards, we'll lose this and it'll start becoming flat or even kind of bow out a little bit. So once we start losing that dicrotic notch, that's one of the early signs of peripheral arterial disease. So that's one of the first things that we're going to lose. So this is just kind of a little bit of a breakdown. So you can see there's obvious changes in your waveform. So when you guys are starting to recognize healthy, what a nice healthy looking waveform should look like. So as we advance through the stages of peripheral arterial disease, so this is our dicrotic notch that we have over here, that kind of bowing backwards, and then with diastolic runoff. So when we start losing that and it becomes flatter, and the more blunted waveform, We start losing some of the amplitude, we lose our dichrotic notch. We still have a fairly sharp systolic upstroke, but we have that absent dichrotic notch and the downslope is bowed away from the baseline. So instead of bowing towards the baseline, it's bowing away. So that's that loss of that dichrotic notch. So that represents, mild peripheral arterial disease. As that peripheral arterial disease starts to get worse, the waveforms start to become more rounded. We become more dampened, so that amplitude becomes less and less. So when I refer to dampened, it's not as high, so it becomes dampened, the amplitude becomes less. And as we get towards severely abnormal or approaching occlusive disease, we just basically have like little rolling hills. I have some actually good pictures as well on here.
And that basically kind of like lets you know that there's obviously a vessel within that segment that's something's wrong.
Yes. Yep, so I mean, if we go from here to here, between two segments, all right,
Yes.
something's going on, or particularly if you go from like here to here, that would be like a major stenotic lesion, something going on. If you, went from normal to moderately abnormal. So this is a kind of a better example. So my labs in New York, we described it as normal, mildly stenotic, and then occlusive. Those are the terms that we used. I know at Christiana, they like to use normal, loss of dichrotic notch, dampened, and then occlusive. So
I don't know why there's not like one stream of
Standard.
like standard, like this is what we call it and that's it.
that's it, I know.
You're.
But the thing is, like, and you guys, you're not gonna be expected to, like, write up your report, so you're not gonna have to do the terminology to write up these reports for them. I just want you guys, to be able to recognize, a nice normal waveform. So we have a nice, very fast upstroke, they come to a nice peak. So we should have, a fairly nice peak. We can see our dichrotic notch here, so it's still bowing back a little bit. And we have a nice diastolic runoff. One thing I noticed when you start getting into mild disease, the waveforms kind of take off right after each other. So I lose this nice diastolic runoff period. So it's kind of like waveform. I'm losing my dichrotic notch a little bit. It's not as pronounced. The peaks start to become a little more rounded. And then stenotic is obvious. Those are my little pyramids. So my little V's. Right now, we've lost a lot of that fast upstroke. It's much more blunted. We have no dichrotic notch. And then something that's occlusive, you may only get little blips. You might not even really pick up a discernible pulse. It's going to be very flat.
But with that, aren't there gonna be like physical things that you can look at their calf and below and notice, like discoloration?
Sure.
Yeah, that's what I was gonna say.
They should.
Like at what point do those normally come in moderately abnormal, or is it only in severe?
If they have like ulcers and gangrene and all that
No,
stuff.
but I mean, you can just color changes in the leg, like you notice maybe there's blood pools.
Or even loss of feeling.
Yeah,
Probably
Like
your
those-
kids, it's moderate,
moderate.
yeah.
Like,
This
what
would
do
be
you
someone
think?
maybe would have like floodication, they're just coming in, they're getting cramp and stuff
Okay.
like that, maybe.
That's what I say, like, at what point would the patient probably notice something, but just be like, like, I'm alright, I just walked too much or
Yeah.
something.
I just think it's old age, you're getting weak, your bones,
My mom right
it's getting stiff and.
You know, it's not old.
now. Well, inside of her, she is. Outside,
Oh,
no, I mean, yeah.
Her soul is.
Well, no, it's just like, cause on Saturday, she was just like, gosh, like my toes are hurting. I was just like, listen, what's going on? And she goes like what, last night, for some odd reason, a couple nights, like they just, like my feet has been, and my ankle, my toes, like I can't feel it. I said, so when you're at rest.
Yeah, right, exactly.
So like when you're at rest.
Bring her in
sleeping,
here.
I was like, are you like, do you have like loss of feeling in your toes, like right in here? She goes, yeah. I was like, do you have high blood pressure? Yeah. Do you have high blood cholesterol? I don't think so. Yeah, you do. Take medicine for it. And then
Not anymore.
I was like, do you have any discoloration or anything out of your feet? I was like, I haven't inspected your body, but she goes, no, not the usual. I was just like, but I know she has, yeah, she bruises easily.
Oh.
I was like, but I was like, I know she has clots all the time. So
Is
I
she
was
on
like,
like anything? is
she's
what-
on like so much medicine. I can't even tell you. But that's what like from the inside, she's like decaying. So I mean, she takes so much medicine.
So Dan,
So I
we
told
are
her, I was
gonna
like, you need to
need
make
a
an appointment.
we're gonna need a fourth person. When.
Can I bring my mom?
Can she bring her mom and we all just hop on her? Legally, she need to start. We'll just answer
See something
questions.
abnormal, like
So Thursday,
And on the
I'm,
weekend.
we're running.
I
right?
know
Like,
over the weekend.
I'm training to run, which makes no sense, but whatever. So.
That makes sense. You're
Yeah.
breathing.
So Andre's like making me do all this stuff, and so Thursday after he left, I was like, "Man, my leg really hurts. Oh no, I'm having pain while I'm exercising." So then like, it turns out, like, cause I made him, like that, I saw him later that night and I was like, it hurts right here. He's like, "Does it hurt here, here?" And he's like feeling all over my calf. He's like, "What?" I'm like, "No." And then he like touched right here. And I'm like, "Oh my God, that's it right there." And it was just a knot in my muscle.
Yeah.
And he was like, he worked it out for me, but I was just like, for a minute, I'm like, oh my God, this is it. This is it. I'm gonna have a blood clot. Or I'm gonna, yeah, I'm not a blood clot. I have hardening of my arteries.
No,
in
my
my
mom
calf.
definitely, like she definitely has stuff.
I just know, because my dad does.
Yes.
My dad
This
had
guy,
terrible, my father's side of the family, horrible heart.
this guy came in on Friday and he almost had the exact same symptoms but we were doing an MSK.
Mhm,
And so we were looking, well, I was looking, she was doing,
mhm.
Kelly was doing it on top of his, like near the dorsalis basically,
Mhm.
and then his bottom of his foot, forget the right terminology, we're good, bottom of his foot. And you can literally see like a notch, like just in between, what is this, segment 2 and 3, she said? I was like, dude. And you could tell like it's like not calcified, but like there's something in there. It's just
Yeah.
like something abnormal in a sense, whatever. And obviously we didn't say anything. She said, oh, your radiologist will have your due. Da, 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 da. Okay.
So what was it in the muscle or was it the bone?
Like one of his vessels.
Oh, it was a vessel.
Yeah, like
I
one of
thought
his
with the
vessels.
MSK, they just looked at the cartilage.
Yeah, but like in between, you could tell, because it's still like a transducer.
Yeah.
They didn't use a hockey stick, actually.
No,
She used a linear one.
okay.
I was like, well, that makes sense. But she used a linear one and it was like in between like his bones, obviously, but like you could tell like it was coming off of a vessel.
Like, did it look like
It looked like to me, like it looks like a cyst.
a pseudoaneurysm with a full of blood?
No, that's the thing. There was like no blood flow. She put that color on. Put some color on it.
Tumor then?
Probably, that's what she said.
Was it dark inside or did it look like it had?
I can't even tell you right now. Can't even tell you. I forgot. There was so many she did that day, but yeah, so she was like, when she left, and I was just like, what would you just, she's like, no, yeah, that's probably like a tumorous type thing.
Wow.
I'm like, dang, she goes, yeah, then he also said, he goes, yeah, I don't have feeling on like 3 of his toes.
Holy shit.
At rest, exercising, pain, same thing. And he was like joking, and he was just like, yeah, probably gonna have like 5 years. And I was like, oh. Her too, Kelly was like,
I
oh.
think three.
I was like,
Yeah, I know. Well, yeah, but you find that people joke about stuff that scares them. most.
say,
Yeah.
me too.
Yeah.
Well, that's me.
But we're gonna die. Steve, yeah. Oh my god.
There, Dan.
Am I drawing over there?
Clearly, there's something wrong. with
You had 6 fingers, 1, 2, 3,
No, that's
4,
fine.
that's 5, damn.
I thought-
That thumb is just really large.
Turn
That pressure, that last pressure cup's a little tight.
Probably on the brachial artery,
Yeah.
so I'm gonna go down. It's proximal.
It's all right.
No, wait till he's done.
Yeah, he's not finished yet.
End of class.
These are the segments.
Right before he asks if we're ready to erase it.
Or you're ready to erase it?
Yeah, and I
You
erase
need
it,
a-
then
Oh, eraser and a blank.
I knew-
You have one.
well, that's because.
You and Jen.
You and Jen just erasing with
Go
your
like this.
arm, it's fine,
Like Jen has like 3 erasers.
but only one arm on that side that she erases with.
Yep.
It's funny. So let's see if we can figure out some of this slide.
Oh,
So if we have our PVR waveforms are so upper extremity, if they're abnormal at all cup sites, so with the upper extremity PVR, we have 3 cups. We have a brachial cup on the upper arm, then we have one at our upper forearm, and then one down by the wrist.
Hmm.
So if it's normal at all segments,
It's abnormal, then you probably cuffed it wrong.
wait, you said what?
I'm sorry, so if it's abnormal at all the cup sites for the arms, we
Mhm.
have to figure out which vessels could potentially be involved.
Then it's gotta be above, so would it be like subclavian or
Yeah.
axillary?
Auxiliary.
Very good.
Oh, well, cause it's right there, I didn't.
We didn't even.
But I will now.
I know, don't share it.
Right?
Wait, wait.
Come on,
Well, Dan's like,
He's like,
"Well,
I
I'm
haven't seen it.
that's good. So
We'll just look at the top group.
that's basically what this is all about, is being able to figure out which vessels could potentially be involved. That's what the board is gonna ask you based on your reports. So if that one's normal and that one's, these 2 are abnormal,
It's probably a brachial or the cephalic.
Cephalic, basically. Between
we're
them.
looking at
We go through the arteries. Okay,
Yeah.
those are veins.
You know why? Because it's our, the test.
Yeah, yeah, yeah.
Sorry.
Brachial.
Brachial.
Brachial artery.
so distal brachial or maybe something at the level of the antecubital fossa, so something down there. So if these 2 are normal and then that one's abnormal,
Radial or ulnar.
yeah, we don't,
Brachial.
there's gotta be forearm disease. So same thing for the legs now. You could figure it out for the legs, you can do the same thing.
So if all of them was abnormal, then it would be your common femoral
femoral or your iliac.
Yeah.
or iliac.
Yeah. Even aorta, if it's both legs, it could potentially be aorta.
Oh, yeah, because
So
of
that's-
bifurcation.
Yeah, so that's one thing too, so you have to, the boards loves to trip you up, so one leg is abnormal, the other leg is normal, fine.
Then it's gotta be the iliacs are.
Then it's gotta be iliac, so if one leg is all abnormal and one leg is all normal,
Yeah,
it can't be aorta.
no, yeah, because it would be both.
It would be both, exactly, so if you can wrap your head around that kind of
Just
visualize,
not- that makes
The
sense.
bifurcation.
yeah.
So it'd be your right iliac in a sense, okay. No, it's not. I couldn't even imagine the fact that I know
Don't get
our
too excited.
right now,
Yeah.
yeah, amazing. That was like, I'm not gonna know it.
No, girl, I'm with you.
Pretty cool, pretty cool. 3 months ago, I did.
But where's the knee on this leg?
It's right there.
Okay. Alright.
You know, babies are not born with kneecaps. It's fun fact, sorry.
Really?
Yeah, babies are not born with knees.
Just cartilage still?
It's just there, and then all of a sudden they actually get kneecaps. I get,
Interesting.
yeah,
Wonder they can like
Yeah, you know,
That's a crazy
probably,
ways.
it was a Jeopardy baby shower thing, that's why,
Jeopardy baby, sure.
yeah, I made it up. Sorry, keep going.
No, that was it.
Yeah, that was it.
No, again.
Oh, that was it for Dan.
Clearly,
Yeah, no, that was it. I mean, if you guys can just kind of visualize,
what's in the leg,
yeah, like where the disease
just
would be, yeah.
not veins.
Not veins, arteries.
Not veins.
Then you can even isolate segments, based on that as well. Um,
What do you, wait, what do you mean?
so like, it's like it's normal, abnormal.
Oh.
Like,
You would never go have a situation, like if it's like normal, abnormal, you would know that it's a cup, that's the issue, like that wouldn't happen.
probably, because wherever abnormal is gonna affect down below.
Everything else.
And everything else would be abnormal.
And you couldn't have a situation with, where it's like where it shows up, where the pressures, it's, sclerosed. So the pressures were the same, but it's. Okay, never mind. So yeah, no, but I'm just gonna go with no, and not try to make things complicated.
I mean, the only thing we have to worry about is collateral vessels affecting it, creating what looks fairly normal. Like a fairly normal tracing if they have a lot of collaterals.
How do you even indicate that though? Like, that's the thing, like.
You
that's
wouldn't.
the
It's
challenge.
an indirect test. Yeah, it's an indirect test. So I mean, if your test is inconclusive, they're still having symptoms, they're not figuring out, they'll go for additional testing.
That's
Something-
We're checking off
That's
like
not-
one that's normal.
Yeah, it's not a problem.
We did the
Okay.
test, we did it.
Exactly. The numbers are what the numbers are. Your waveforms are what the waveforms are, If you've done your steps,
Picture, freeze it, there,
yeah,
Yeah,
and you're on your. that's
Yeah.
it.
exactly.
smack one butt, get out of here.
So I mean, if you're like, all right, this doesn't make sense, you recuff, you redid it again,
Yeah.
you're getting the same exact thing. It is what it is.
That'd be hard for someone who's in pain though.
Well, sure, because I don't know what's wrong with me.
Yeah.
No, but like, imagine like we have
Like
to
doing it?
recuff
Oh, girl.
and
let me
someone
tell
who
you.
has like ulcers.
Oh, yeah, no, they scream. They yell, they scream. They're like, oh my God, no, I can't do this.
I gotta tell
I
you
know,
about
I'm
this lady,
sorry.
it has
I'm
nothing to do with
serious.
this. I'm gonna tell you about this lady on Friday.
Do you- Sorry, before you do it, do you still
no.
continue though? Do you just still continue?
If
I'm
they were,
totally
no, if
saying
they, if they refuse and they can't do it, I'm like, no.
So what if like they have an ulcer like literally by where you're supposed to cuff?
If
Like
they have
that
an
nasty
ulcer,
stuff,
I mean,
I get gauze and like,
just put stuff on it and then
non-adhesive
just
to
wrap
cut,
it.
yeah, and then wrap
no,
it.
that'll make me throw up in the trash can.
We have,
Me.
there are covers sometimes that you can put on the cuffs too, like a plastic disposable
Okay,
cover.
That's,
sleeve that
yeah,
they
that's
have.
cool, because.
I don't know, I'm kind of weird, these gross stuff.
Sometimes
is
they use a
kind of
chuck.
weird
Like, I don't know, I'll put like a couple chucks, and like,
to
If
me.
it can't be anything too thick or it could
Can't
affect
do that,
the, I
can't
mean,
do that.
especially if they already have that, I mean, you really wanna get as accurate a measurement as possible.
Interesting, sorry, what was your story?
No, I can't tell it here.
so
I mean, I.
usually they can tolerate us wrapping it. And they can usually tolerate this, but when you have to do a pressure, that's when they go, woo. Like,
Because it's.
Yeah,
easier.
yeah,
it's way
Yeah.
more.
Oh,
I mean,
makes
if you
sense.
can at least get a waveform, you'll get a little bit of information,
You're just taking the pulse at that point, yeah, no pressure.
Yeah.
Well.
Maybe you can get a pressure above
Just
it.
kidding. Dang, poor people. There's this woman that came in on Friday and she was just like, my back and everything and whatnot. Did a whole ultrasound, it was completely nothing.
But
I
I
was
mean, I'm
like,
sure
this
it's
woman,
something,
I was
but
like,
it's.
someone got a pinch her, I was like, you want a massage?
Oh,
Kelly was
yeah.
laughing. I was laughing. She goes, it probably is actually.
Yeah.
I was like, should be alright, I get those like every 2 months.
Aw. Back pain is no joke.
So our limitations for our PVR, so kind of what you were saying, Amy, was if we have disease high up, if it's inflow disease. We don't get a really good picture of what's going on below because that's gonna affect our
Yeah.
waveforms going down below.
Mm.
So it's we have some limitations with that as well. And then motion and tremors, patients who aren't able to stay still.
That makes sense, because obviously,
Yeah.
like, if all your pressures are abnormal, but then you're like, okay, obviously, it's nothing to do with the legs in a sense, it's
It could
all
be-
something.
It could be multiple locations in the legs and you wouldn't be able to
To
tell.
really tell, yeah.
Or that
It'd be
big-
hard. Oh, yeah.
You gonna die.
I feel like there's like a invention here somewhere to make this better.
Yeah, you
Somehow,
can, it's
some
called
way.
contrast dye. You just put that shit in the
Angiogram.
legs and then you take a picture of them and it's like, oh.
Your
black and cute.
angiogram, well, that's why angiogram is still the gold standard,
Yeah, because it's expensive.
Listen.
because it's
It's
invasive, you can't,
expensive.
if they have
Oh,
kidney.
it's invasive, oh,
Well, you gotta put
Obviously,
contrast, yeah, you gotta put in a catheter, inject the contrast, and remember,
Some
these
people are
patients,
allergic to the
yeah,
contrast.
these patients are diabetic. If they're diabetic, they're probably gonna be on dialysis too, and they have kidney problems,
Walks down the street.
shoot.
well. I guess, on a detailed anatomy for a woman who's pregnant is like $800 without insurance. I said, that's cheap. But
See how much they charge for a bag of saline fluid.
you know how much a baby costs, like big.
Yes, I do.
Hospital, I said, oh
Yes,
my
I do.
gosh. I was like, who's insurance? He's like, John, I was like, oh.
So this PVAL machine, we can bring this up to the OR, can be done portably, so we can do this as intraoperative monitoring. To see if, and the recanalization, the procedures that we're doing in the OR are successful or not. Can be used in the recovery room after the procedures, operative. So it's portable, you know, we can take this machine wherever we want to go. This is a really old school machine. This is what's actually buried over in the corner. It's a somewhat newer one.
This is so old.
The harsh flow lab, so. So this is just showing our normal plexus sonography volume pulses. So just one thing to kind of take away is that the amplitude, the size of that waveform is gonna be larger in the calf than it is in the finger or the toe, just because it's more volume of blood that's being displaced, so we're gonna get a larger tracing. Just kind of keep that in mind. But you're looking for the features of that waveform. So even though it's small, it should still have the same similar features. So something you guys might notice is that when you get below the knee, the cuff just below the knee, or the calf cuff, tends to have a higher amplitude. Just because we're getting flow volume from both the profunda and the splenicular arteries. So you're just getting some increased flow there.
But that's normal. See, but you just.
Some of these.
But it says like it's, but, okay, so sorry, so when, we were referring back to the other charts, right? The one that you went through, like mildly, blah, 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 blah.
Yeah,
So this one, you were saying that like a flow of diastolic or something like that,
yeah, it looks like you're losing some of the diachronic.
Yeah.
but like it doesn't have like that
Yeah,
steady
that's
dias.
Yeah. I agree with you.
What is that word that you're saying?
Yeah, the diastolic runoff.
Runoff, yeah, so like none of them are normal,
But they are though.
but they are.
And
See,
this is why I don't wanna do vascular, because that's bullshit.
So
because when you were going through
wait
it,
till
I
we
was-
actually get to these guys, like real patient studies.
none of them have it.
Yeah, well, that one, that look, the low
So like
side,
this is
I thought
considered like this is diastolic
Yeah.
runoff. So this is more.
So really the only one that doesn't is your right, the digits. I mean, the one on the right, I think it's a little bit. Yeah, they still do. I feel like mine don't look like this.
They don't look like this.
Don't think
I'm not gonna lie, when I was doing it and you just referred to like the runoff and such. Overall abnormal.
No,
Well, we
Too much coffee in our veins.
too fast. both of you.
Monster in 3 days. you
Oh
know.
gosh, you're going miserable.
I really am.
You're like, I'm sad.
I'm not sad, I'm just not awake tired.
So the boards, and for me, the differences are gonna be really obvious. The boards is not gonna give you something like this in a very mild change. I expect you to see that. They're gonna be like,
Okay.
Oh, like literally like that,
literally something like that, like, you
Great.
know.
Well, that's good.
pyramid
because
hills,
I hate that shit,
Yes.
like,
Normal.
like little
questions.
things.
Yes.
If it doesn't have a notch, but everything else is Great. Okay, so obviously that's easy,
Yeah, but in real life, we need to know.
not at all.
In real life, you need to know, real life, you're gonna learn, it's a process. Your entry level sonographers and every place knows that,
No, I need to know everything now.
you don't need to know. That's what I need to keep reiterating.
So I have a
Like,
question.
I was working in the vascular lab this summer, I was like, how would you, like, what's the verbiage you would use? Cause I know how I would say it, but like, they want their specific verbiage, how would you
Yeah.
describe these? And even the most seasoned textbook, that's, what do you think of this waveform? What do you think of that word? Like, I'll ask Kyle, I'll ask me,
To
like,
get a second opinion.
Yeah, like,
It's
what do
better than having,
yeah, like, you
Too loud.
ask each other, like, what do you think of these waveforms? Like, yeah, that's normal, maybe mild, you know?
okay,
So you could ask people's opinions,
Yeah.
you're not pigeonholed in a corner, like, we're like, oh, I gotta just, you know, it's okay to ask. It's always okay to ask.
Well, no, that's why I don't wanna work in an outpatient area where like you're by yourself when I wanna work in like a hospital or something and just be like, I need everyone around me.
that's all, so is it the same thing in a vascular, outpatient place, there's only one person?
Vascular outpatient offices,
Yeah.
sometimes it depends how large of a
Interesting.
practice it is. I mean, if it's just like a vascular surgeon's office, there might be 2 techs.
Okay.
Yeah,
I just don't wanna be
alone.
alone.
Remember was like, I wish Dave would just go to that little lab at Christian. The studies.
We'll make it, well, no, that's too far away, never mind.
Next summer.
Yeah, I know, just make an appointment for next summer.
Yeah, right.
She'll be fine till then. Lots of leafy greens, I don't know, that makes a difference.
So normal, abnormal. So looks pretty normal, I see.
Yeah, the right is normal.
The dichotic notch, and that one, looks like we're losing that dichotic notch.
But it's not terrible, because it's not like super rounded.
It'll be slightly abnormal,
Yeah.
Mild. for-
Mild, I mean.
Mildly,
that's the second
mildly
one, right?
stenotic.
Stenotic.
So this one has a high amplitude because of the presence of collateral vessels, like we wouldn't necessarily know that, unless we did the angio, but
Yeah.
that's kind of what
I'm
they're
gonna be
saying.
writing that up in a.
Oh, Krishna would say loss of dichrotic notch,
Yeah, they were just. saying
Instead
loss
of-
dichotic notch.
mildly,
Yeah,
whatever.
yeah.
But I feel like, okay, so who does this go to after you, like, say, where does it go to from you? The cardiologist?
You write your preliminary report, it depends, for vascular stuff,
Yeah,
some cardiologists would read vascular stuff, it's usually either a radiologist that's licensed in vascular or a vascular surgeon.
because my
Oh.
point is this, like, so your job is to get the images and to write up your
A little
report, though.
preliminary report, yeah.
But like,
They'll look at your
There-
report, they'll look at the numbers, they'll say, all right, I agree with that, yes or no. If the report then might get kicked back to you, be like, I just want you to change this statement or this sentence, and then they'll sign off on it. It's usually how it goes.
so you're just doing all the work.
Haven't
So
you
that's-
learned this by now, in the past 6 weeks, maybe?
General ultrasound and OBGYN is a little different. Well, with OBGYN, you're getting all the measurements for them and putting them in the report and the
Yeah,
package
that's great.
usually.
OBGYN, I was like, maybe
Abdomen,
this
you're
is
getting a
wrong.
lot of measurements, and you're describing things sonographically with general ultrasound, and then
That's
they
interesting.
go into a little more detail there, because then they have to kind of diagnose off your ordinary stuff.
I still find it fascinating, like, I really, 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 like, I know, like, in my heart, I still wanna work with babies. And
I
maybe
do
I'll change
too.
my mind, and I'm like, you know what?
But it's okay.
Maybe if I get a job there, I can change. Like, how things are.
So I was
Like,
thinking that
you know?
too, but then I was just like, I could work at B120, I could do like all of that.
Yeah. Like, we could work together at maternal fetal.
And then have each other.
Yeah.
Tag me.
Each other.
Yeah,
You and Amy.
So,
we'll make our own clique.
Anyways.
We'll be nice to everybody.
so upper extremity waveforms look a little bit different than the legs. To me, they just kind of look
Inverted?
chunkier. Yeah, oh, they kind of do look a little inverted, you're right.
They just look
If
inverted
you
to
look
me.
like
Yeah.
that.
It's an M sign instead of a W.
Yeah, so I mean, these are all examples of normal looking arterial waveforms for the arteries of the arms. The same thing, they'll have that dichrotic notch, so that's one of the things you're looking for.
So a dichotic notch is kind of like the what is it, landmark, I guess you can say, in a sense, like. To make it normal, abnormal.
Yep.
Okay, cool, cool. Cool, cool. Notch, 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 notch. I guess they're all normal.
Yeah,
I was gonna say, bright digit look kind of sus, but
right digit.
I guess the notch, I guess there's a notch,
Yeah, there's a notch.
okay. Well, these numbers don't make sense, though, just saying. Like, what, 41, dot, 11.06, where go, okay.
This is just showing the importance of using was it the same amplitude settings and inflation pressures for each segment to ensure that it's normal.
The right leg doesn't look normal. Compared to the left leg.
Can you, if you do the test wrong, like say you don't have, I mean, you can definitely alter the findings by not having things set up properly, right? Or maybe
Yes.
not having stuff calibrated.
Yeah, we could. Yeah, you can make the amplitudes look way different, the waveforms look much smaller.
Wait, so was the right leg normal?
So right, like normal,
Maybe mildly.
I was gonna say, is it
I think
mildly?
Either one, like, I mean, they look like similar, but the right leg does look a little worse than the left. Because at least on the left, you can still see the knot,
Like all the notches in the left.
yeah,
I mean, and you can still see it, but it's like not as defined, I guess. But you still have the problem, I don't know,
So the right leg is without.
you would think that that was fine, like, that's fine.
Really?
yeah, the only thing I,
It's normal.
like, it looks like I'm losing it here. a little bit,
Yeah.
like, that first one, but.
But then if that's the case, then it would be like that on all of them, right?
Gotcha, yeah.
That right leg.
For the first one, that's not
So
without.
maybe it's just not tight enough.
Just too much pressure.
Does this slide say anything? Does it slide say all normal? Really?
Okay.
In your notes, I don't know if you have the teacher notes on. But
He's a teacher, he shouldn't need the nerd.
I know, you have to know these things. Gosh.
Doesn't know.
He
other-
doesn't know, it
Doesn't
doesn't know. Actually, just skip this.
It's the patient alive. I'm totally fine.
They're breathing. Normal.
See, teacher notes, told you. Yeah, see, that's trippy. If that's on the board exam, I would fail that.
No, you wouldn't, you'd be fine.
Well, clearly I just got it wrong in
You
class.
can't write stuff.
No, I can't. I can't put that. That's dot, question mark. You know what, Jasmine? You are
That's,
correct.
this guy has problems.
Yes. Hold on.
This is totally bad.
I mean, all the way. Like, I mean, I would say, go check this motherfucker's iliacs. Or it's both legs the aorta.
Or yeah, as I say, Sarah just said aorta, so if it's
Yeah.
both legs in aorta.
So again, we said that disease is proximal or at the level of the cup. It's kind of similar to what we just said, right?
Yeah.
So some more normal, abnormal, right, left, level of the abnormality,
Level of what?
abnormality.
And that's
Well,
LE.
on the left, I would say, the iliac is up super high in the thigh. On the right looks normal to me, well. I mean,
So his left leg is like complete. Good.
Yeah, this left leg's a lot worse.
So left
yeah,
iliac?
they're not amazing, but.
Yeah, you could say aorta,
Yeah.
aorta, iliac.
Oh,
worse on-
yeah.
Worse on,
Like worse on the left.
Worse on the
yeah.
left.
worse on the left.
So that,
Yeah,
What did you say was the normal, like the range in which the pressures could be different, like more, you're like.
40, 30 or 30?
30, we look for,
Oh, yeah, in between 30, yeah.
so we're gonna get into a moment where now, first step is look at your. Well, I always tell, first step is go right to your ABIs, your ankle breakout index, is the ABI normal or abnormal. So here we actually have a normal ABI.
Oh, no, I'm on the left.
So this is abnormal in the left. Then once we look at the ABIs, you can tell yes or no, which side's normal, touching normal versus abnormal, and then you have to go look at your waveforms. And then look at your pressures.
But the pressures. look
The right
normal.
pressures, it's normal, so then I would say the right is kind of alright. If you're comparing it to the pressures, then it's like, okay. This is just how you're right. It's probably like that because of the right iliac, I mean, the left iliac, you know, like the pressure, I don't know, I'm just thinking
If
of
it's
like
included, it's gonna be sending.
affecting the right leg a little bit.
Which even if there's
That makes sense.
fluoresces, we could have,
Yeah,
sort of if it's slightly stenotic, it's still gonna have to handle the blood.
yes,
So it
okay,
can increase the pressure.
just kind of like in a sense of like common sense,
It has to go somewhere.
right?
Somewhere,
So probably like left iliac, most likely.
what do you think about his great toe?
It's gonna be.
Probably
Right, purple,
Blue, yeah.
right, purple.
Yeah.
And stuff,
all kinds of bad colors.
angry.
So the reason too,
It's hard.
part of the reason too, we do this test first with the waveforms is this is gonna help guide us. So if now down at the metatarsal, it's very dampened, the toe is dead, we're trying to listen for pulses down here. It's gonna be challenging because there's not. much
Yeah, that
blood
was my
flow.
next thought process, cause I'm like, okay, what if like that whole leg is messed up in a sense, like, so where do you,
Flat.
yeah, and you're like.
Yeah, so if I do this and I see flat, like in, flat at the ankle, there's no blood flow getting to that ankle cut. I'll then come up to the popliteal and try and listen for a popliteal pulse to see how high up I can get. So if I have no pulses down here, I can't hear, I'm trying, I'm still, even if it's flat, I'm gonna try.
In the tibia. and
Yeah,
the-
try and find posterior tibial, try and find dorsalis pedis. If I can't find them and they're inaudible, then I'll just come up to popliteal, see if the guy has a popliteal pulse. And then I can at least get pressure at the low thigh and high thigh.
You can't, well, yeah, I guess you can't get the pulses from the. I mean, the pressure is from underneath if you go to the popliteal artery.
No, yeah, you can't get pressures from underneath. Yeah, pressures are just at you're taking the pressures
Above.
at the cuffs. So I'm insinuating at the popliteal and I'm getting enough pressure here,
Yeah.
and pressure here, yeah.
Dang. So in that sense, like. The conclusion, would it be like amputate that leg or just,
Oh, we don't know yet. I mean, there's more testing that has to be done. Like
Oh.
then they would do the oximetry test. Sharing that.
what's the opposite? Oh. Well,
Oh. It looks like there's problems right
With the
below the
ankle.
thigh. Like below the right thigh, between that and the calf cup.
well, no, I would say ankle up, like between those two segments from popliteal to ankle.
Well, it's definitely, that like, well, because all the pressures below where the issue is are gonna be bad. So, I mean, that looks occluded, like below the thigh at some point, like it's after the thigh cuff, but before the knee cuff. Or around the area, that segment there is where there could be multiple blockages, but there has to be a blockage, like a pretty severe one.
Yes, yeah, like
Between
right there.
these two
Yeah, yeah, yeah.
areas to cause all the rest of them to be
Mhm.
like flatlined like that.
So they're only doing a 3 cuff method.
So
Oh, so I'm sorry, so it's.
So
I
they
was
have just
thinking-
one thigh
So it's not,
cuff. It's actually-
okay, so it is
It's
below, it's
ankle.
below the knee then.
yeah,
So need wait a minute, what?
popliteal to,
So
To
there's
ankle.
2 ankle cups?
So it's getting your dorsalis pedis pressure and your posterior tibial pressure. So it's really only one cuff, but you're taking 2 pressures with that.
Okay,
ankle.
so that's why,
Yeah, so
Yeah.
we're gonna see in a moment pressures.
so it's below the knee.
Yep, so it's below the knee. Like, well, it could be.
In that area.
Yeah, that knee, so.
But you are getting a pressure at the knee, right? Isn't that what that second one?
Yes, you're getting a pressure at the knee, which is 132. Or 196.
And it doesn't look like that, what is it, the Brewy or not, that's just the sound, it doesn't look like there's no back, well, I mean, I guess you wouldn't be able to tell that on there, would you? So it has to be below that sensor, it's still getting good waveforms there, even though they're losing it a little bit.
So most likely it's
Calf.
That's like it,
yeah,
yeah, your calf, basically.
That sucks.
or. Well, it could,
Well, and we're thinking about arteries, so then wouldn't it be like the tibial artery maybe? Or the, what's that, the front one, the
Well, there's the anterior.
anterior one?
could be anterior tibial.
Yeah,
But over here on the left, oh, is that the toe? Okay, so maybe the toe would be different. But on the left toe, I feel like that is a much sharper waveform than that one. Does that make a difference or no?
we'll see that, I would think that has like a runoff or whatever.
Yeah, well, with this, like, this is actually using that PPG sensor.
Okay,
It's-
so it's different.
Yeah, it's very sensitive, so you can get a much sharper, crisper tracing.
Gotcha.
So plethysmography versus Doppler waveforms. So I'm gonna have on my tests, and I know for the boards, they're gonna want you to be able to recognize the difference between a plethysmography waveform versus a Doppler waveform. So the Doppler waveform is when you're just using that pencil probe and we're getting the tracing, arterial tracings. With the plethysmography waveform, there is no baseline. So a lot of the drawings I'm gonna give you are gonna have a zero baseline going across. So you can tell right away the difference between a plethysmography waveform and a Doppler waveform. So Doppler waveforms will have that zero baseline, so you can tell if something is triphasic, monophasic, biphasic. Whereas these plethysmography waveforms, we don't have that. Actually, spoke about plethysmography.
This S and then Mo Crappy. Fluffy, Fluffy's Mo Grappy.
I'm never gonna pronounce it any other way.
Fluffy's Mo Grappy. Like, yeah, Fluffy's Mo Grappy. What's this? I don't even know how to say it now. Normally.
Plethysmography.
Plethysmography. Yeah, I like my word better. Fluffy's Mo Grappy. I bet you'll be able to attest now.
Yep, I will.
So Doppler waveforms will always have that zero baseline, so we can tell if it's triphasic, biphasic, monophasic. Whereas the plethysmography waveforms do not have that zero baseline. They kind of look different, you know?
Yeah,
I think so.
yeah, so if you see anything below the line, you'd be like.
Yeah, but where's the line in the waveform right there? The Doppler waveform.
You mean the plethysmography?
No, Doppler waveform.
Doppler waveform,
Is it just like
flat,
that third
right?
line?
it's where this red line is, so kind of like.
Oh, where the red line.
like
It was
that.
all under.
Yeah, it's not right, like, I don't like this picture. Here, let me see.
Cause I was gonna say the other graph has a red line.
Yeah.
Oh, I thought you had a separate detachment for that one.
Good. So the tracings I'll give you on the test, you'll see this obvious, like, baseline coming across.
Wait, oh, okay, so if you see a baseline.
Yeah, basically, you'll know it's a Doppler.
Or Plethys. Crappy.
we'll go over more examples, like one before our midterm. We'll be going through case studies like Doppler or versus, plethysmography,
Is that our
normal,
next-
abnormal. The next test.
Is our middle.
Next quiz.
midterm? Oh.
We have a
Quiz
quiz.
before that,
Yeah,
okay,
we'll do a lot of studying too.
for the midterm.
Yeah. We got this, don't worry.
Well, I know arteries and veins, so I feel pretty confident in that field.
Let's see, strain gauge plethysmography, so this is another form of plethysmography. Again, that's measuring volume changes. So this uses, little, mercury filled, sensors that are attached to the caps that, transmit those volume changes into a recorder. So this is not widely used as well.
Probably because they're rubber tubes filled with mercury, because that sounds unsafe.
I was gonna say anything
Like-
like mercury, I feel like.
Well, I mean, it's not so, like, until you accidentally like pinch it or roll over it or something, and you have mercury all over the floor. Like, that
Yeah.
just seems like a bad idea. But, whatever.
Like
It's
it's
science.
filled with mercury liquid, like.
It's Science,
Yeah.
it's fine.
There's impedance plethysmography, it's the same kind of similar principles. This uses electrical electrodes to sense those volume changes.
Could we still do this?
No.
Okay, let's keep skipping. I heard you right here, like, nah, I'm not gonna worry about it. See?
Then normal. Which is mildly stenotic, and then it goes
Yeah,
to-
A is normal. C is.
Well,
C is bad. B
I'm
would
not
be
gonna put
slightly.
that when I explain it.
B would be slightly.
So this would probably be like the first method that they developed, like, hey.
Those
we
water
can-
displacement.
Yeah, the water displacement, exactly. Oh, let's stick a person's hand in there and see how much water gets displaced and like with each pulse, and then we can get a
That's
trace
really smart though, when you
Yeah,
think
when you
about it,
think
like,
about it.
these people, like, I mean,
that came up with something like this.
I'm not understanding this.
it's physics, girl. You'll
Oh,
learn it next
That's next
semester.
semester.
So we filled up this, contraption with water. And your pulse as it's coming into your hand will cause the water to displace, like,
Oh, like a
Slightly
dolphin.
bigger.
kinda, yeah, like you're making ripples in water.
Sorry, that's how my mind works. Sorry, go ahead.
Dolphins.
I don't know, sound wave, waves.
Kinda, yeah, it's like
It's
your
totally
pulse
waves.
is-
I hate y'all. You're like,
So like the same reason, like, when you get into a bathtub, the water raises up when you getting into it, like.
okay,
It's just on such a smaller level, they have to
Yeah.
be super sensitive.
Pick
Yeah.
up those changes, yeah,
like there was a person that actually thought this.
yeah.
I was like, you know what? Let's stick my hand in the body of water.
Like, physics is so, fun. Like, it's so, there's just so much, it's like, it really, really is.
Like,
Like,
someone was
once you
really
understand,
smart.
they can like figure out anything, it's so crazy, I love it.
So again, we said photoplethysmography, this is not considered a true plethysmographic technique. So this detects cutaneous blood flow and pulsations rather than volume changes.
Oh, okay, yeah.
Yeah, so there's an infrared light that gets transmitted into the superficial layers of skin, and there's a photo sensor that receives the reflected signal. So this sensor picks up basically the number of red blood cells in our cutaneous circulation.
It's the one that they put on your finger at the doctor's office, or not
Similar.
at the hospital, whatever,
Like similar to pulse ox,
pulse ox, okay,
and that's measuring oxygen concentration or saturation.
What?
that makes more sense.
This one is measuring the actual
How many?
number of red blood cells.
Yeah, because because some people have lower levels of blood cells, especially if they're sick, like,
Anemic.
yeah. So that's gonna alter things.
But, yeah.
So why do we use it?
It's good for a very slow flow. Patients have very slow flow states, or there's very poor circulation. It can also be used when there's arterial wall calcifications. So we oftentimes do this for those diabetic patients, particularly if it's non-compressible, the vessels.
Use this.
We use this to try and get some information about the toes. So this is used on the toes than the digits. So we're not slapping the sensor on like their ankle or their thigh or anything like that. This is only for digits. So this is us to get an idea of like, what's going on in their feet, because typically that's where we're gonna start amputating when they start losing toes, and the whole foot, and then potentially below the knee, and then potentially have to amputate above the knee. So it's those smaller vessels are the ones that are gonna be affected first.
But like at some point, if these people aren't taking care of themselves, they're not changing things and they're slowly being amputated away. Like at what point do you go like, do you really want the surgery or do you want us to just like let nature take its course?
Well, you do ask that for, like, I guess.
I mean, because
you
I
do,
feel like as a doctor, I would be like.
You have to
"It's
treat
really
it,
what
and
you
surgery,
want,"
they're not
like,
just-
It's up to the patient at that point.
Oh.
Do you want to keep doing this? Sure, all right, guess I'll see you next week. Do this all over again. Not funny, but it's funny.
Yeah.
159 slides.
So
Nervous laugh.
no, we're
well,
not.
y'all have been lean.
Don't do that.
That's not way too.
I know, I said y'all.
Y'all.
I'm three, you're not three.
I'm tired. I'm fucked out. So our PPG sensors, we put on the fleshy part of the digits, so we can use a clip.
Oh my God, it really does say use doubles.
Yep.
Those are horrible pictures.
Get up.
Yeah, we use double tape.
That's so sad.
It's the same thing, red right, yellow left. So we can use it in conjunction with the pressure cuffs to get digit pressures. So basically, we wait for us to get our tracing, we inflate the cuff until that pulse goes away, and then we look for the moment when that pulse returns to acquire our digit pressures. So we should have similar looking waveforms to our PVR waveforms. So abnormal PPG waveforms. So we can detect maybe the presence of proximal obstruction. So we utilize PPG when we're looking at the digits. So we're going to be worried about patients that have Raynaud's disease and Raynaud's phenomenon. You guys remember the difference between those two? Raynaud's disease, Raynaud's phenomenon.
I don't.
So Raynaud's disease is the primary condition. So this is the patient, they come in, they got blue fingers, blue toes, and this is a result of some sort of stress, either cold or physical stress. They're in a stressful environment, they're a very nervous person, and their arteries all of a sudden constrict on them. So sometimes they'll wind up with pain in their hands, their fingers will become blue or very pale. So primary Raynaud's disease is just that constrictive disorder that all of a sudden the vessels just constrict on you in response to cold stimuli. So that's the one where you have to remove the stimuli, put on mittens, put on gloves, extra pair of gloves, extra socks.
Isn't that what happens in like gangrene, but not, but that's like extreme cold? Because your vessels all constrict, so they're not getting blood flow and then it turns to chronic.
Yep. You're trying to conserve that core body temperature,
Wait, you said something was significant about the Raynaud's disease in the beginning. You said this is the.
So this is like the primary disease, yeah, so like this is just that condition alone where they have those vasospasms where the vessels constrict as a result of that stimuli.
Hands become discolored.
Yeah, so they can become discolored, blue, very pale. They call it the red, white, and blue. Sometimes because like it become very pale up here, and then this part gets very red, and then it can become very red when you start to reperfuse it. Raynaud's phenomenon now. This is Raynaud's disease with some sort of peripheral arterial disease. So this is actually worse than regular Raynaud's disease.
So it's Raynaud's disease with,
With
peripheral
arterial, some sort of underlying peripheral arterial disease. So it could be some proximal occlusive obstruction, some blockage somewhere else, higher up.
And with this, you just get all the symptoms with both, in a sense. So like you get the discoloring.
Yep.
Constricting. Raynaud's? Like nod.
Raynaud's, yeah.
But does it make it worse? Like, does it make it happen at other times? Is that why it's a phenomenon that like? No, so it's just that it happens with cold, or can it be, you said stress as well? Or just?
Yeah,
cold?
stress, whatever the stress stimuli that causes,
Stress stimuli. okay.
yeah. So it could be cold, I mean.
But can it be brought on by just like, I don't like doctors, I'm scared where I am?
Sure. Yeah, if that's
okay,
a
so
stressful,
it's not just.
yeah, whatever's stimulating that response in the body to cause the vessels to constrict. Yeah, so it could be a stress stimuli like physical stress, like
Okay.
emotional stress.
For both, right?
Yes,
Disease and not.
yeah, but just phenomenon is worse, because it has that, peripheral arterial disease component to it as well.
Stimuli.
So you're probably more likely to have, like issues like,
Like it progressing to like gangrene or something
Yeah.
like that, yeah, so it makes it worse.
So this is caused by a stimuli or?
Raynaud's disease is caused by a stimuli, so something has to cause that constriction.
So besides, testing, being diagnosed with it, are there any like remedies or anything that, a person can do to kind of, I don't know, you know what I mean, like, with other things, it's like, oh, we put stents and this is kind of like, more so temporary fix, but it's not as much of a primary issue as if it goes untreated,
if there's no cure,
yeah.
because if it's kind of
Like a psychosomatic thing.
Yeah.
Therapy, I guess, I don't know, work on managing your stress levels, Zan.
Something like this is caused by stress, this is great.
like your sister, I mean, like she's scared, she goes to the doctor, like
Yeah,
something like that, or stress would stimulate, I mean, if she has that disease, it can stimulate them.
that would suck because then you would be
I know it's gonna happen, oh god.
like, then no, but like in a sense, like you don't have anything going on, but like. You're stressed all the time, you go to a doctor's office and like, but then you go home, like everything's all normal. And like every time you go to the doctor, oh, you might have a disease.
But they would probably be able to figure that out too, like, I mean, I'm sure,
I don't know, like every time you go to the doctor, you're stressed though.
I feel like on some level you probably are, everybody is, like.
Every time I go to the doctor, my blood pressure is so low. It's
Really?
like, yeah, low blood, right? No, I'm dead inside.
Me too. Me too. So the waveform for Raynaud's disease though, is that super high, the diachrotic notch? Or like what, how can you explain that? Like, why does it look like that?
B, right?
Yeah, like, why is it like, okay, so it goes up and then it's like, meh, and then like,
Meh.
yeah, and then like, I mean, would that be considered the notch way up high like that? or
Yes,
no?
yeah, so that's one of the telltale signs about Raynaud's disease, you get
Okay.
this. Elevated diachrotic notch, that's like basically like all the way up by that peak.
And why is that? Is that not important for us to know? Cause you don't have to tell me if we don't need to know that.
He did a side, so it's not.
I know, I'll Google it later.
Well, wait, this is not a Doppler wave, this is a Plethy wave, right?
Yes, this is a plethysmography.
Would it be the same on Doppler?
So what, don't they look inverted? We established that in a sense. Right?
Well, I mean, it's not, it's not. technically
I'm not
inverted,
saying it's
like-
inverted, but I'm just saying it just looks like that. W sound but backwards. Like like I would say B is normal, but A and C is not. Just looking at it. Or am I completely like off?
A and C or not.
Like A and C are not normal, they're.
Yeah,
they're
so I mean,
abnormal.
these are caused by obstruction. So A is caused by a proximal obstruction. So this is a PPG on their sensor. Like on the patient's digits. So say like a hand, well, we'll do the hand for this case. So this would be caused, A is caused by something obstructing it higher up.
Okay.
C would be that proximal obstruction plus Raynaud's. I mean, they look pretty similar. So it'd
B
be
is
kind
a
of,
Raynaud's disease. B. That looks normal.
just primary Raynaud's.
These reports are local people.
Um,
Email.
oh, I know. Let's see if I got a good one here.
With a hoodie.
The hoodie.
Yeah, I hope they can make those.
Something that also you might see in in a waveform that in a patient that also has vasoconstriction is something called an ancrotic notch. So it's a little notch on the other side of your peak,
What is that called?
an ancrotic notch. So we had a dicrotic notch on the other side, and then an ancrotic notch before it.
And carotid.
Ancrotic.
Is it on the next one? Oh, it isn't on the next one, on the next slide.
Yes.
Anacrotic.
I know I found better pictures for the like the ancrotic notch. Like on my test, I was like blatantly obvious.
So anacrotic notch is before
Before that
The-
peak systolic,
the peak, okay.
yeah, the peak systolic at that point.
Okay.
Some measure showing like ancrotic notch. So,
This one's abnormal,
yeah, first one's abnormal.
stenotic, or at least mostly.
Yep.
And then the second one looks like Renaud's, but
This would be Raynaud's, like a peaked waveform. So peaked is Raynaud's. So that we may see an ancrotic notch, and that dicrotic notch is positioned higher on that downslope. And then an obstructed waveform, we have a low amplitude, rounded peak, absent dicrotic notch. This would be like obstructed, and then the other one would be a peaked waveform. with Raynaud's.
Is that always Raynaud's? Always.
That's always Raynaud?
Yeah, this peaked waveform
That's Raynaud's disease?
disease, yes. Phenomenon would be one that looks like
More
obstructed, yeah, because it has that obstructive disease with it.
And that's always Raynaud's phenomenon.
No, the phenomenon, because that really doesn't have a notch on the anterior side of the peak, right? So that's just the high notch would indicate.
The Raynaud's.
But if it's on the other side, it still is the same, right? Like if they have it on if it's the
And chronic notch.
anacrotic, that also indicates Raynaud. It's just, yeah, but.
Yeah. Whoa.
Wait, okay, so you're saying obstructed, like the pulse contour basic, I'm just going off by that chart, so obstructed is Raynaud's phenomenon?
Yeah, so Raynaud's phenomenon has
Phenomenon.
I can't.
phenomenon has an obstructive, has a obstructive component as well.
But
Oh,
the
that's
graph on the right, the Doppler on the
So
waveform on
this
the
would
right,
just be Raynaud's disease.
disease, right?
Primary
Okay.
Raynaud's disease.
So now it's be peaked.
Yeah, peaked, yep.
Okay.
So over us.
No, I'm just,
Sorry,
no, you're fine. It's just, it's a lot. It's a lot of information.
but I'm getting it.
That's good.
Asking questions.
So this is just now just comparing some of the different digits,
Oh, gosh.
which could potentially be affected.
Which ones are affected?
Which ones are normal? and
I would
normal?
say. Your left, what is it, the left ring finger
Yeah.
looks
Yeah.
affected.
Definitely.
Right,
Same
The
with
right,
finger, too.
right
right
middle,
ring
right
finger,
rear.
it looks like the right middle, yeah,
right middle.
the left middle.
Yeah, your whole right hand.
Rock. Well, yeah.
This finger's not too bad. Thumb's not so bad.
Yeah.
Not as bad as.
The
these.
So middle
Yeah.
finger,
Definitely not.
Definitely, okay.
you wouldn't say middle finger, because that's hot, that notch
Yeah.
is high.
It's high, yeah.
See, I
It
say
looks like
index,
it's starting to get here, really
Uh,
affecting those guys.
interesting, because I would say index is right finger index, the notch is high to me. Not as high.
Not
as
as
the
high.
middle finger, but. So left middle fingers were. Kind of abnormal.
Yeah.
But the
Right, sorry.
pressures, that's weird, cause like the right middle finger pressure is the lowest on, yeah, on that right hand, that. Pressure is 23. I mean, I guess 1 degree. of
Yeah,
pressure is really that big a difference, but. Yeah, I guess.
Your whole left hand is gone.
You might
You're
wanna-
done, Judy.
you might wanna cut somebody.
Well, Betty, your
I mean, but wouldn't that include, wouldn't that possible, I mean, is that, would that, I mean, cause that's nothing, so that just means that there's a blockage somewhere. Along what the dorsal, oh no, it's somewhere along in your
Your
hand somewhere, like, or upper before your
So
fingers.
this one, they're actually, this test, they're actually doing,
Did they even hook it up to the left hand?
at this point.
no, what they did here was actually, they're testing, the palmar arch. So this is all the left hand actually, and they did, with
Oh,
the,
with compression,
yeah, so they compressed the radial artery.
gotcha.
And when they compressed the radial artery, they got all flat lined.
So something's going on the radial artery, basically.
Yeah, so with this was a modified Allen's test. So what they were doing was they put the PPG sensors on the digits. And they're testing the radial artery to see if they could potentially harvest that radial artery for bypass. So
Sometimes
sometimes.
no, cause you would have no
Exactly.
blood flow to your left hand.
So we have these palmar arches, so we have the
Yeah.
deep palmar arch and the superficial palmar arch that should both bring blood flow to the hand and perfuse the hand. So if something's issue here, we should get blood flow from the ulnar artery and then that should be sufficient Perfuse the whole
So
hand.
that would mean that there is an occlusion in the ulnar artery.
Yeah, somewhere in the palmar arch, there's something blocking it, so this would be an incomplete palmar arch.
In the ulnar artery? Not in the
No,
radius?
it's, the issue is in the palmar arch.
The radial artery is blocked, so they got no blood flow, so there's no blood flow going into, from, like, the ulnar artery isn't able to.
Isn't supply
make
blood flow
it-
to the hand.
Yeah.
Yeah.
So if they let go of that, they got the waveforms on the other side, so there is blood flow getting to it, but it's not from both arteries, just from the one.
Oh, so if you compress the radial
And to make it not.
to see
flow.
if your ulnar is good, but obviously it's not,
Yeah,
and then vice versa in a sense.
Yep.
yeah, so if they were
Thank you
compressed
for
the
identifying that
ulnar,
for
it
me.
shouldn't change anything.
We're actually gonna go over an Allen's test. This is what's called a modified Allen's test. They would do this and then they would then compress the ulnar artery and see what the waveforms look like
Should
with
stay
the
the
ulnar,
same.
hopefully.
Hopefully.
That was done back in 99.
I know you saw that, Betty Rose.
She's no longer with us.
Yes, here.
Laughing.
Like,
Who took that artery anyway?
it's horrible.
Next
We're
woman you see with-
sick-minded
Oh,
people.
good. You're Betty Rose. Damn sonographer took mine. He had a good laugh.
Come on, guys, we got 103 more slides to go.
Oh, Lord.
Oh my
All
god.
right. Segmental limb pressures now. So we started, being able to take limb pressures in the lab. So for this test, when we're looking at the lower extremities, we're gonna insonate our radial artery, get our brachial pressure. And then we insonate or listen to the dorsalis pedis artery, as well as the posterior tibial artery. Again, we can either use a 3 or 4 cuff technique, depending on the lab. So really one of the main thing we're looking for when we do these pressures is we're trying to calculate our ABI, or ankle brachial index. So it's important for you guys to understand that formula, that calculation.
Great.
Yeah, no, it's really simple. So I just always just kind of draw my division sign between the A and the B. I know what's in my numerator, I know what's in my denominator. So ankle to brachial, so ankle is gonna be in your numerator, your brachial pressure is gonna be in your denominator. And you just gotta remember, it's the higher of the 2 brachial pressures, so we always are gonna take. We always do both brachial pressures and we have to use the higher of the 2 for this calculation. So regardless if it's which leg you're assessing. You take the higher of your 2 brachial pressures to put it into that calculation.
I get that, but like, why is it only one ankle pressure?
So
Like,
this is
not the highest?
well, we take the highest of either the posterior tibial or the dorsalis pedis. So we take those 2, remember I said go with the highest of the 2 to do the rest of your study. So it's your ankle systolic pressure, so it's either the highest, the higher of the either dorsalis pedis.
It's either the PT or DP.
Yeah, it's every report's gonna spit out both of them. So if like I went back.
Okay.
Where's our? Do I have? Put one there, huh? Now they're making liars out of me. There you go.
What?
So we calculate the 2 pressures, one like 112 or I'm sorry, 211 and 188.
Just take the PT.
Yeah, so when they calculated this pressure, they used the higher of the 2 brachial, so 187.
So
So
211 divided by 187.
correct, yeah,
Okay. That's easy. That's an easy equation.
yeah, it's an easy equation.
So this is the measurement of blood pressure in that specific segment.
Yeah, where that cuff is, so we're taking the pressures at the level of the cuff. So it's that blood pressure wherever that cuff is. And then we're gonna evaluate pressure differences between two consecutive levels. And then we're also gonna compare horizontally, side to side, so at the same level, comparing right to left. So those are the two comparisons that we'll do when we're looking to, like, you know, write up our preliminary reports and assess for disease. So this helps us to also identify, you know, the presence and severity of the arterial occlusive disease. We can use it as a baseline pre and post operative. Evaluate treatments that we've potentially done. And this should be done in a resting state. Unless we're doing the exercise treadmill test, but it should be done when the patient rested. So it's just kind of explain what we've done already. So when we're intubating, we're trying to assess for these pulses. We want to inflate about 20 to 30 millimeters greater than that last detectable arterial signal. So once we stop hearing that pulse, we want to continue to inflate a little bit more to just give us that time for it to run down. We slowly deflate the cuff and we're listening for the return of that arterial signal. And this is that systolic pressure, that top number in the blood pressure that we're getting. Can be done for upper extremities as well. So same cuff placements, we have the brachial, and then we have a proximal forearm, distal forearm down by the wrist. Lower extremities, we have the brachial. And then when with the ankle, we intonate the dorsalis piece and posterior tibial. ABI. Ankle to brachial index, it's the systolic pressure in millimeters of mercury divided by the higher of the two brachial. Just our 3 cuff and our 4 cuff technique. Just remember that the benefit of using this 4 cuff technique is we can, if there's disease in the thigh, we can kind of differentiate segments. So we can tell if it's aortoiliac versus, you know, just femoral disease. Whereas if we're just using the 3 cuff technique, you know, it could be femoral or it could be aortoiliac. You can't really differentiate, you know, between the two.
Yeah, why would they do a 3 cuff then?
These pressure measurements tend to be a little more accurate in terms of the thigh pressures. The cuff fits a little bit better, you know, it's has this more like conical cylinder, like as opposed to
I
the other
guess
cuffs.
the whole like comfort thing, but.
These are just the insunnation sites. So our posterior tibial artery, dorsalis psoas artery. If the patient doesn't have either one of them, if you can't find those pulses, maybe that artery is occluded, maybe there's no flow, then you can go up to the popliteal, try and insunnate the popliteal and at least get pressures for, you know, your 2 thigh cuffs. So that's always an option. Goes over those insunnation sites. Guys, I'm really impressed. You guys have done really well with this. If you come to the lateral ankle, the outside leg, the lateral malleolus, you could also potentially listen for the peroneal artery. That's another site. That's not typically used.
If they don't find the PT or the DP, they would go to the
Peroneal?
peroneal?
No, they
They
would
would
just
go
stay,
popliteal,
yeah, they
right?
just come right up to popliteal, yeah,
Okay, so just like that.
yeah. Well, I last year I had someone that was insunating out here thinking they were posterior tibial, because they were getting the pulse and they were doing the study, they were confident and they were doing it from there. I'm like, oh God.
You didn't stop
I did, like, I didn't go too far.
them? They just let it be. So you did this whole thing wrong, like,
It's like, come to the medial malleolus, medial, like, what do you mean, medial? Oh, okay.
they went in the middle of the gap.
So PVR SLP interpretation. So the arms, that window is a little more narrow than it is for the legs. So we look for differences in pressure that are about 15 to 20 millimeters of mercury. So I like to use the high end. So when I see differences that are greater than 20 millimeters of mercury, that could potentially indicate disease. So if I'm doing my brachial pressures, like say I have a lower extremity study and I'm doing my brachial pressures and I have a big difference between the two arms, I'll automatically redo it because maybe I'm cuffed bad or cuffed incorrectly, something's going on. I'll just kind of verify that there is a greater than 20 millimeter difference in mercury between my two brachial pressures. Because that could potentially indicate occlusive disease more central that this patient may never have even known about.
So it's 20 for upper and 30 for lower.
30 for lower, yeah. Normal limits for our ABI. So our normal ABI should be within a range, 0.9 to 1.3. So kind of think of it as a test score, you know. You get a 90 and then you get some extra credit, 130 on your test, but I kind of always think of it as like a test score, like, you know, so like. You want to be around 100 for your test. You want, essentially, you want a 1-to-1 ratio,
Yeah.
brachial to ankle. So you want around 1.0. It could be a little less, could be a little bit more, you know, typically if you're healthy, young, it's gonna be above 1.
What is ABI abbreviation for?
Ankle.
Ankle,
index.
brachial index. Yeah, so put your little
Divided sign.
divided sign between your ankle and brachial, and then you have your numerator, and your denominator. So you know which pressure to put in your numerator, which pressure to put in your denominator.
Alright, good though. You want an A, you want to pass. I need a vote. Cool. You're fine.
Pressures tend to go up as you move up the legs. So if your thigh pressures are typically going to be greater than 1.2, and this is normal. Toe pressures, they typically range 0.8 to 0.9. So this is just for upper extremities.
Should wear leggings on this one. It is cold.
So so this is one of the charts that you're going to see in a lot of places. So again, normal 0.9 to 1.3. 0.9 to 0.5. We also refer to as let me see if I get the other one. I like this chart better. Hold on. Yeah, so here. So 0.9 is normal. Once we get less than 0.9, we start getting into mild symptoms. Claudication. That's not right there. Hold on. Rewind. Claudication is 0.9 to 0.5. Here's my rest pain chart.
What is that? I don't see anything on your chart.
I don't see it either. See if I uploaded it to D2L. Waveforms.
This is the ADI, right?
Yeah.
Okay.
Remember we talked about like the different levels, like claudication, rest pain, and then gangrene, like ulceration, gangrene.
Yeah.
So. That's
These
what,
are the
yeah, that's what the board does, the registry does, like, in terms of the numbers.
Yeah, but what if it's like 0.9
Or,
or 0.5? No, because the quota case is 0.5 to 0.9.
Up to.
well, then it would have been 0. Then it would have been 1,
9.
Alright.
and it would have been 1, so it's.
Point,
I know, I was gonna say, I'm
I
being
know,
very
I
like
know.
specific, but like,
up to 0.5, so like from 0.2 up to 0.5.
Well, then shouldn't that, the claudication, shouldn't that be?
0.89999.
Yeah.
It's like you're being too specific.
So what Dan's
If
saying
you
is that it's.
nail
not
this on the
responsive.
dot, I will pay you $1 million. Like,
Yeah.
you're gonna be on one side of that or the other.
Okay,
Just making sure.
and it won't be a board test, they're not. gonna
Watch
say-
me like, watch me be the only one who gets
It
it.
was 0.9.
I'll be like, be right back. My professor.
My professor.
Yeah, he needs to write me
Do
a
you
check.
remember 2 years ago, you betted on this?
That's right.
It
was all recorded,
It
I'm
always,
sure.
it always goes out several decimal places.
Interest and now it's $30, like.
God, I hope I never see that in real life,
I hope I don't.
just
So-
like.
So the
everything.
pressures always go out 2 decimal places. So like when it, it'll calculate ABIs. Like, you know, when you're calculating your ABIs, it always goes out 2 decimal.
2000.
Yeah, so like if you land on the nose 9.00,
Okay.
then you can come back and be like, ah,
I can
damn.
call you. That is, I want to take a picture of this real quick. Some proof. So we don't round. With this test
No, you'll report it out.
as like that, okay, so
0.12,
it's not like regular.
Yeah.
Okay.
you'll report it out to the 2 decimal places.
I don't know if it's less than critical
Ischemic,
ischemic, okay,
yeah, critical ischemia or ischemic changes. So I think gangrene, ulcers.
less than 0.2. This. I always want to say ischemic.
Ischemic changes, gangrene, ulcers.
Oh, it's like all possible things with that, it's not like a regular.
Yeah, like
Gotcha.
tissue starting to die, like at that point.
So it'll be clear.
Yeah, those are really low. Man, that's not right at all. Less than 0.2 rest pain. Yeah, here they're showing, they have less than 0.3 as critical peripheral arterial disease. On their little chart.
Oh, they just break it down even more
Yeah, this
in
is,
between.
yeah, this is theirs. So again, we're looking for differences, 30 millimeters or less. Normal high thigh to brachial index, so when we look at those pressures with high thigh should be normally greater than 1.2. So that's gonna help us when we start looking for potential aortoiliac disease, when we see thigh pressures. When we get our index that are less than 0.9. Let's see what we can go.
So you just do the ABI once. To get. I don't know if it's like hard to even think about, so by segments in a sense, right, or is that what we're just about to like learn? Cause like the ABI is like the whole thing. Does that make sense, and not by segment? Cause you just said
ABI
thigh
is
brachial index,
just
so
the ankle pressure.
that's about it, okay.
Yeah, so ABI just refers to the ankle brachial index.
TBI is thigh. Or
TBI, yeah, would be thigh brachial
brachial
pressure index, yeah.
But ABI is the most important.
Let me see
to
if I.
know.
Well, they're all important because we're comparing. Let's see if they have it here. Our machine, here you go. So this is an example of our machine. So it's spitting out an index.
Oh, it's already doing it.
It's doing it for you.
Oh,
So
We just never noticed it before because we didn't learn about it.
we didn't learn about
I
it.
didn't learn about it. So this is us. This is our thing. We have our
Gotcha.
ankle pressures. Our posterior tibial dorsal pressure,
Yeah,
and then spits out an ankle brachial index. So that's your main basis.
same basis,
Makes sense.
yeah,
And then you're also getting an index for each level as well.
makes
Yeah.
sense. All
So
right,
you have all these numbers. Now it's you just kind of looking at this and digesting these numbers. Trying to
makes
figure,
sense,
trying to figure it out.
okay. All right,
Well, this would be, example of a normal looking study.
looks normal,
And they should have adjusted kind of, I mean.
they're brachial,
Yeah, they adjust that. Nice calibrated.
it looks fine.
It looks fine.
Yeah, even for the left one too.
This looks relatively normal, no?
It's almost mirroring the right there.
Yep, so that's one thing too, you wanna look right to left. So first thing I always have the students do is first look at your ABIs, alright, those are both normal, so that's a good sign. Then after you look at your ABIs, then you can start looking at your pressure differences, see if you see any pressure differences between segments. Any pressure drops, 236, 220, no. No, so no significant pressure drops on that side. 240 to 25, still, it's not 30. It's not 30, no pressure drops on that side. Then you can look at your high thigh pressures to see like, if they're both greater than 1.2, so that's normal. So no evidence of iliac aorta disease, everything looks similar. Brachial pressures are okay, there's no significant difference in those two. So that could be an incidental finding.
So they're just there for no reason. They had a clear.
Necessarily. So what about this guy now?
Yeah, ABI is way low, so. He's in that,
Yeah, so
Okay.
first thing, go to your ABI, for low on both sides.
Would that be considered right on the top, like, or is that just like?
That's choppy movement,
Choppy,
yeah,
okay.
that's just,
so this is
I
resting.
wasn't sitting still?
probably could be.
TBI is hella low.
So brachial index, very low. All right, so we know abnormal bilateral, So you say abnormal.
Oh, sorry, abnormal,
Yeah, abnormal bilateral, so then you know, right is worse than left.
yep,
Now you have to go and look for pressure drops now. So like between segments, I don't see any major pressure drops, they're just all really low. Because I look at this thigh to brachial index, that's very low. This is kind of low, it's a little low,
mhm,
but we use 0.9 is kind of like that threshold.
Cut off. You
That
have to
that cut off, yeah,
somewhere.
cut it off somewhere.
Mhm.
So once it drops below 0.9, I go, yes, there's definitely disease in that vessel,
So you just wanna definitely keep an eye on it.
yeah.
so probably your right leg, common femoral artery,
Or iliac, yeah,
or
so
iliac.
anywhere,
well.
so the disease, remember, is either at that cuff or above that.
Yeah,
Got that, sorry? That's, wanna make sure everyone's on this boat. Together.
I think we're rowing.
We're sinking.
I think we're on the boat.
Please. You're taking on water.
I got the ABIs in comparison,
But both ABIs. Or abnormal,
Yeah, they're both abnormal.
so.
So really I see like kind of like the biggest change, going from, so.
What was
This
he
was
looking at?
your high thigh cuff to your low thigh cuff. Like the waveform for me changed the most
Mhm.
there, it went from really high amplitude to something much more dampened.
Hmm.
So there might be some disease, somewhere kind of in between there, like almost getting to 30.
Mhm. Yeah, there's a lot going on in this one. What would be the question? Is this normal or abnormal? And why and where? That's abnormal. Ooh. Thanks. Okay.
This one. No, it's this one. There we go.
Yeah, we know what he said.
You said right iliac disease, right abnormal. Left high thigh index is 1.0, 1.01. We have mild aorto disease, mild iliac disease. Also maybe between that high thigh, low thigh, because that popliteal artery has a much lower amplitude
On the left leg.
on the left leg, yeah.
Okay. I think you just have to like really take your time
Yeah, just.
and just look at the numbers, look at the graphs.
Yep. So first thing with your ABIs, we have a normal ABI on the right, abnormal on the left.
Mhm.
So the left has disease.
It's definitely,
The entire leg too.
yeah, so it has to be left iliac or left,
Yeah, left iliac. Starting at that high thigh, pressures are very low. Iliac.
Is Is it normally, like, do you find that it's a lot, that it's the whole leg, or is it really just variable? Like, you don't see one blockage in one place more than another?
So common sites for blockage, aortoiliac, distal femoral is a popular site, and then small vessel disease.
Is it like in the neck where, like, whenever a bifurcation happens, plaque tends to build up and it can be more to one side than the other?
Yes, yeah, so the iliacs for sure. Here when that femoral is running through that abductor canal, it creates a nice place for plaque to start developing. So here's a good example. So are these PBR waveforms or are they Doppler waveforms?
Well, on the left, there's the,
There's a baseline.
Yeah, so it's the baselines.
I would say on the right was Doppler. Well, I guess no, because it goes below the,
These are the
Yeah.
baselines, these are baselines, these are the Doppler waveforms. This is just kind of hugging the baseline so you can't see it.
Yeah, his toes gonna be cut off.
right below that.
It's nothing, yeah.
It's gone.
So they couldn't even hear a dorsalis pedis, so they weren't able to insulate a
Oh, wow.
dorsalis pedis.
Yeah.
And posterior tibial, they got pressure of 22. Yeah, so his ABS,
PCI 0.17.
yeah, so that's critical.
You're gone, leg.
You're not leaving. We're gonna have to do something.
Did you see anything abnormal? We see a doctor something. Is it your leg chopped off?
Don't put your shoes back on. You know?
You put my shoes on? Mm-mm.
So here they use Doppler and the segmental pressures.
But seriously though, like what would the next steps be with a patient like this? You don't wanna leave, right? Because they have no pulse in their foot. I mean, how did they?
Yeah, that would be a critical finding.
Yeah, like,
Yeah.
I hope you didn't drive, that's your right foot.
Yeah, like what, just curious, what would be the verbiage? Like, I'm pretty sure you had to like say that to someone, right?
In terms of like not letting them leave, like,
Yeah, cause like you found a weird finding.
or even like a blood clot, like, yeah, so I just gotta show all these, to the physician, hold tight, for a second.
Student scan on you. Don't let them fucking leave.
To me on Friday, and I was just like, oh, there's something, cause she was just like, all right, I'm gonna run this over to the doctor, and she said that, she hasn't said that all day, and I was like.
Yeah.
But I can't see nothing, cause I didn't know.
That's
what
when
was
what?
going on. I was like, she's like, just scan, and she was like, yeah, that's fine. I said, okay. Patient was just like, is that normal that she goes to? I said, "Yeah, totally. And I'm over here like,
So did you just sit there and try to find what she found?
yes,
What was it?
it was an MSK, so that she told me, Kelly, when she came back, the doctor said it was fine, like whatever.
Yeah.
But she's like, there was something that she was kind of concerned, but in a sense, like the radiologist there, I guess, like said, like, if you do an MSK, you have to show me the MSK.
Yeah.
That's how, I mean, she did a couple of MSKs when I was with her.
Yeah.
And when I was at AI, they do MSK too,
Mhm.
and it's more so, I guess, making sure that the radiologist is satisfied with their.
Yes, yeah,
images.
basically. And I was like, did you see anything abnormal? She goes, I thought I saw something abnormal, but the radiologist said, oh, I was like, oh. To me, it just all looked like lines.
Yeah.
Yeah, she's like, this is the, what's my favorite? I think it was the median, cubical nerve they cut. It was just like a circular thing. It's like,
I don't know.
I probably would have.
Those would be